Hi everyone, let's take a closer look at dopamine. Now usually when I'm reviewing medications, I start with the pharmacology and I get to the dosing later on. However, with dopamine we have to combine the two because the mechanism of action of dopamine actually changes as we increase the dose of the medication. So let's start by looking at the range of dosing of dopamine, which is 2 to 20 micrograms per kilogram per minute. Dopamine is always administered micrograms per kilogram per minute. Now, if we start at a very low dose, 2 mics per kilogram per minute, they believe this is kind of what they call a renal dose. Helps to dilate the mesenteric arterial system and helps with renal kidney perfusion. It's debatable, it's controversial, that's that. Once we move up to 5 mics per kilogram per minute, and I want to highlight 5 because that's kind of a magic number with dopamine infusion, we'll get back to that later, but between 5 micrograms per kilogram and up to 10, the mechanism of action is predominantly beta in the heart. So beta is going to increase the rate of contractility. It's a positive chronotrope. It's going to increase the force of contractility, so it's a positive inotrope. So somewhere between 5 and around 10 mics per kilogram per minute, it's predominantly beta. Now, keep going. Let's go past that 10 up into the 15-20 range. Then we begin to have alpha effects kick in. And alpha is peripheral vasoconstriction. Alpha is out in the vessels. So now we're truly pressing the patient. We're causing vascular constriction to raise the pressure. And we get to the golden rule, always fluids before pressors. If you're causing vasoconstriction and your patient is volume depleted, there's nothing to press. You can't raise any blood pressure. There's nothing in the tank to press. So remember, fluids before pressors. So what's important to note is as we get past that 10 mic range, we're not lessening any of the beta effects. We're simply, in addition, adding those alpha effects. So now we have all the beta and all the alpha combined. Okay, so what are our indications for dopamine? Well, it's the second drug of choice in the bradycardia algorithm if atropine is ineffective. Now remember, if you're giving dopamine to raise the heart rate, we want those beta effects. And that's going to occur somewhere between 5 and 10 micrograms per kilogram per minute. After that, we're moving into alpha, vasopressing, and that may not help to raise the heart rate, especially in bradycardia because the problem is a low heart rate. You're also going to find dopamine in any algorithm where hypotension is a factor. Now, if we look at the packaging in our dopamine, we have 400 milligrams in 250 cc's. It also gives us the concentration. In this case, 1600 micrograms per cc. That's the concentration. The concentration is always how much drug per cc. What you have to be careful with is if you're going into the ICU, the patient may be on a concentration of 800 milligrams in 250. Remember, these are often heart failure patients and they can't tolerate that extra fluid. So we double the amount of drug. That changes the concentration to 3200 micrograms per cc. How does that impact us? We have to make absolutely positive we know the exact concentration before we flip them over to our pumps to transport this patient. Okay, so this has been a quick review of dopamine, wonderful drug. I'm Mark, thanks for watching, see you in the next video.